also at Takwa at 9 a.m. And then we'll crown it on Sunday, the 30th of July, with a walk with hope. And this will start from the UMAT Basic School, also at Takwa, at 5 a.m. And this is a family and friends affair. So please do well to join us. Come and let's celebrate Hope Channel Ghana at 5. 5 years of impacting and changing lives. So for the consulting room today, we have a very important and interesting discussion. We're talking about postpartum hemorrhage and other complications in childbirth. Pregnancy is such a long journey, and we are all expectant that at the end of it all, we'll have a very happy celebration with a bundle of joy. But how do we make sure that both mother and child are doing well during pregnancy, during delivery, and then even after? So today, we're going to talk all about that, and we have someone with a lot of experience and knowledge to help us with this. So we have with us in the studio, Dede Gau, and she's a midwife. Dede, you're welcome. Thank you for joining us on the consulting room.
Thank you so much for having me around.
Okay, it's a pleasure. So we'll go for a quick commercial break. When we get back, I'm sure you're excited to tell us all about this.
Of course I am.
Yes, so we'll be right back. Please do stay tuned.
He is the Alpha and He is the Omega. He is God all by Himself. There is no other God that can be compared to our God. He is such an amazing God, and we love Him because He has first loved us.
Oh yes, come and meet Jesus at the Goldfields Junior Staff Clubhouse, Akon Takwa, on Saturday, 29 July 2023. At exactly 9 a.m. as Hope Channel Ghana and the West Central Ghana Conference invite you to the all-white family prayer conference. I will be there together with your favorite pastors. So come prepared to be inspired and experience Jesus to equip you to lead your family in prayer with wisdom and purpose. Kai said, Womua and Ama Hope Channel. Actua so jumedie sonko abesi sa empempensi enti wo ba fa bibi hye wabosuo mu anase fa bibi hye wo botomu a o de ba beboa Hope Channel eye jumedie ahodo a yedie no kai se jumedie e ba so eye memeneda 29th of July 2023. Hope Channel Ghana, 5 years of changing and impacting lives.
Minia, bra, my uncle, Hope Channel Ghana, me at Yassam do, put our suppose made that also at your son. I think the Nunia Dunia Sam, and Yassam Kituo, or say ye the American Tuo, ye free Uma basis cola, ye Namu Kakra from Fadam Foy, let me unfriend Mio, ye Quamrica, and ye Mika, Kakranwa, ye didn't know. Obia Benyana Chefa, who said Apomodin, Papa. Ye repena ye call community center, a whole and the aerobics are not yet in so. And yes, some Kituo, the Patrol Pabawati, the Brana Apomodin, and one for so brave. Hope Channel in Finum, Tapa for Yelimuana, and Shiabomo. And yes, some Kituo, Hope Channel Ghana, yes, it's a proper Hope Channel, ye ma edita so.
Welcome back to the consulting room. If you are just joining us, our topic of discussion for today is postpartum hemorrhage and other complications in childbirth. And we have with us a very experienced midwife, Dede Gau. Dede, you're welcome again.
Thank you.
Okay, so for pregnancy, usually you have someone who has missed their period and then they test, and then it's positive. So after that, what do you do?
Okay, so if you realize you are pregnant, like you rightly said, you will test with a strip you can buy from any pharmacy or chemist, and then you realize that you are pregnant. The next appropriate thing to do is you would want to have a scan done to actually confirm that you are pregnant.
Okay.
Then from that stage, you would want to visit any nearest hospital of your choice. You think you would get a good care. So upon reaching there, you would want to go to the antenatal clinic, because that's where we take care of everything about pregnancy. Okay. So you might want to go to the antenatal clinic. They would actually confirm that you are actually pregnant, and then the care begins from there.
Okay.
Yes.
Okay. So what should you expect at the antenatal clinic?
Oh, actually, you should expect everything.
Okay.
You are pregnant. All the known, all the uncertainties and all that. You should expect everything. You should expect that you are going to meet a team of professional health workers. You are going to meet nurses, midwives, your OBGY as well. So those are people you should expect that you are going to meet. And then the next thing you should expect is when you get there will be series of conversations or interactions with you to know actually if you had planned for the pregnancy or not. You should be expecting that you are going to have some screenings done, some labs are going to be done, frequent examinations are going to be done, educations on several things you should know are going to be done at the antenatal clinic. I think, and a lot more of things, you are going to meet a lot more of other people in your same situation at the antenatal clinic. So there are a lot of things you should expect that you are going to meet, which you didn't even know before, or some you had already met before.
So is that something like too early a time to start antenatal care?
There is nothing like too early a time to start antenatal. I mean, like you rightly said, if you confirm you are pregnant, I don't know why you should be at home to wait till maybe the baby bump is out before you start coming for antenatal. I mean, pregnancy is so uncertain. You do not know the outcome. You don't know what is going on. Some might think, okay, I have been pregnant for once or twice before, so I would want to wait. Remind you, every pregnancy is different. So we mostly advise that as soon as you feel you are pregnant, you have your test and you have your scan, just come to the hospital for us to start taking care of it, so that if there is any abnormality, we quickly find it, or we rectify it, and then we save you and then your unborn beautiful child. So there's nothing like too early or too late. As and when you find you are pregnant, just pick. Yes.
Okay. Okay. But how often are these sessions held, the antenatal care? How often is that? Okay.
We do not have a fixed number or a fixed duration or something. So let me say that, I mean, the minimum one should come is, even if you wouldn't come for antenatal, the minimum is 4 times.
During the pregnancy?
Yes, that is even the minimum. But then, for how frequent you would come depend on your health, if you're a low-risk person or a high-risk woman, and also sometimes depends on your hospital. So mostly what we do is, let's assume you start the clinic early from conception. So from, let's assume 0 weeks. We don't have anything like 0 weeks though, but let's assume 0 weeks to 29 weeks. You come monthly. So within that time, every month, you come once. Okay. When you get to your 29th week to 36 weeks, you come every 2 weeks. From 36 to probably 39, 40, 41, 42, you come every 1 week. Okay. So that's how, for my facility, I mean, that is how we see them. But if it's somebody who is a high-risk mother or expectant mother, we might want to see you more often than the usual. Okay. Yes. So I think that is how the frequency is. So it depends on the condition of the pregnant woman. Is she okay? Is there a problem? And all that. So we see you during those periods.
Okay. Okay. So which kinds of pregnant people do you refer to as the high-risk ones?
Okay, so maybe somebody who has hypertension in pregnancy. Apparently, it's either that maybe she had a hypertension before she was pregnant, or maybe the pregnancy had induced the hypertension. Maybe diabetic mothers, a woman carrying multiple pregnancies, twin or triplets. Those are some of the women we would refer to as maybe high-risk mother, or a woman who had been having series of miscarriages. So those people, we want to give them extensive care. Or a woman who is quite old and then she's now getting pregnant. So there are a series of people we refer to as high-risk women. You know, pregnancy, we all pray that is normal, but then we have some that are abnormal. So those are the 2 ways we can go about it. So the abnormal ones are those I've just said or talked about. So those people, we pay close attention and monitoring to them.
Okay, okay. But what are some conditions, apart from these ones, that you can pick up during this antenatal care?
Okay, so let's assume maybe a pregnant woman. You know, most people often wouldn't go for regular checkups or screening or labs. So maybe during the antenatal school or clinic, when you come, we might want to run series of screening or labs on you. So if we find out that any of these are reactive, maybe your HIV status, your hepatitis B, your syphilis, sickle cell, and all those things, we pick them from all the scans or screening. So we would also want to give you enough of care. We have people that I mean, they are quite old. They don't know so much about pregnancy. That is their first time. But because you've come to we find out that you are old. So we would want to give you intensive care. We have people that might not even know they are hypertensive. But because they come for regular antenatal, their BPs that we check on arrival would tell us, okay, this woman is quite prone to getting this condition. So we might want to put in extra effort in caring for her. So those are some of the things. Or maybe bleeding. You might not know that, okay, when I bleed, it's a problem in pregnancy. So when you come to complain to us, we would want to help you. So there are a lot of little things we find out during the antenatal, and then we let you know during the process of care.
Okay. So there are some routine medications that we put pregnant women on, and folic acid is one of them. What's the benefit of folic acid during the pregnancy? Okay,
so sometimes we might want to say that even when you are preparing or trying to get pregnant, you should even start taking the folic acid. So let me say in a common way that so that your body system absorbs it. So what folic acid does, minimal is, it helps to, keep you healthy. It helps to maintain your blood level. People say blood level, that's the hemoglobin level. And then what it prepares you towards the baby when the baby is actually received into the womb. You have the formative stages, mostly the first trimester. So this folic acid helps to prevent any formative defect, mostly the brain defect or spinal defect, what we call the neural tube defect. So this folic acid helps to prevent most of this defects. So mostly being the first trimester, your first month, second and third month, we would want you to take just the folic acid solely. So it prevents most of these birth defects. So mostly that is what it mostly does. Then maybe we might want to add other routine drugs, like you said, which helps also to prevent anemia and all other little complications in pregnancy.
Okay, but are there some medications that aren't safe during the pregnancy?
Yes, I would say there are lots of medications that aren't safe during pregnancy. I wouldn't want to pinpoint them. What I would say is your routine drugs, they are safe for you during pregnancy because as recommended by your midwife or your OBGY. But then anytime you want to take any medication, I think the best you can do is speak to your OBGY, speak to your midwife, speak to a nurse. Do not just walk into a chemist or a pharmacy to buy any drug. So for me, I would just say that every medication is harmful during pregnancy. It could cause an abortion, it could cause a miscarriage. It could cause other birth defects, which you might not even be aware of. So I think every medication, apart from your routine drugs, is dangerous in pregnancy unless it's recommended or prescribed by your doctor. Fine, you're able to take it.
Okay, so we know generally that alcohol and smoking are like a no-no. Even for like a regular person walking around, it has a lot of harmful effects. But people still do that during pregnancy. So just for education, what effects do they have on the baby and even the mother?
Okay. Thank you. Like you rightly said earlier, it has effect on even the normal person who is not pregnant. So if it does, so imagine that little baby in you, the effect would be outrageous than even you who weren't pregnant by then. So what alcohol does, alcohol is when taken too much, you are intoxicated and all that. So what it does is it can cause this syndrome we call fetal alcohol syndrome. So taking it, maybe even if it doesn't have any physical effect on your baby, when the baby is born, you see that the baby looks a kind of way, like the baby is dizzy, or the baby is bruised with some funny facial expressions. There's something like that. You can read on it, and then it can also even cause abortion or miscarriage. Okay, it can also cause your baby to be born too early, preterm labor, preterm delivery. It can also make your baby to be smaller than the usual weight, which we call intrauterine growth restriction. So instead of your baby growing to the pace at which the pregnancy is going, your baby is growing smaller. So you born baby, even when baby is 10, but the baby is so small. I think that is just similar to the smoking, cigarette smoking, or any other smoking as well. They have the same effect on pregnancy. So we wouldn't recommend that. Pregnant women should smoke during pregnancy or even when preparing to get pregnant, even during breastfeeding and all that. I don't think it's right for you to smoke. So these are some of the effects, but there are other intense effects. But if you see that these are some minor effects, so imagine the intense effects of these things. So we discourage that. You shouldn't smoke or drink alcohol when you are pregnant. Yeah.
I mean, that includes passive smoking too, right?
Yes, there should be nothing like smoking at all.
Yeah. So are there any medications that, not medications, food that someone who's pregnant shouldn't be eating?
Oh, okay. Before I actually answer that, you could, sometimes, I mean, people get pregnant, they tend to crave for certain things they didn't even like before, certain foods, or there's aversion, what they even like before, they don't want to eat it. So those are some of the reasons that bring these things. But then when it comes to what can't I eat when I'm pregnant, mostly we just want you to reduce your sugary foods, the spicy foods you take, you should reduce it. And caffeinated foods or drinks, that one actually, we would want you to stop them because it has caffeine effect on the baby as well. Apart from that, I mean, there's something we call chili. People think it's quite healthy, it's whitish, a clay or something.
Clay,
it's not advisable for you to eat. Pica, so any unhealthy food that you think, no, this food I shouldn't eat, we wouldn't encourage that you eat. So anything that you think is healthy, lots of fruits, vegetables, your stew, your soup, I mean, you eat them more. People are able to eat, but I mean, you should try to eat something, because if you don't eat well, or if you eat those foods, unhealthy food substances, you are prone to anemia. You are not doing your baby any good. So those are some of the things we would want that if you are pregnant, you wouldn't eat. Apart from that, you can just go about and eat any food you think you can tolerate. Yes, so I think basically that's it.
So in pregnancy, people usually say you're eating for two. Is there like any truth in that? Are you like eating for two? Should you double what you're supposed to eat just because you're two people, or like what portions are allowed? Yeah.
Okay, so eating for two actually is a saying, but for me, I don't think it's a must. Mind you, when you are eating for two, like you are eating that big bowl of food, your baby is growing bigger. We have something we call, what's the name? We have microsomic babies. They are, apart from diabetic mothers who have big babies, when you eat uncontrollably, your baby might tend to be very big. So the complications are that you might not be able to have a normal vaginal delivery. Even if you have, sometimes there are complications during that. So one thing is you might want to monitor your diet. You might not want to overeat. So that's the best. You might not want to overeat, and then you should be considerate of what you want to eat. If you are the type that eat often, then you should do a lot more fluid, fruit and vegetables. So you reduce your carbohydrate intake, because you're also managing diabetes. You do not want to overeat and then have issues with that as well.
So earlier on you mentioned bleeding that can be picked up when you come for the antenatal and all that. Is it a normal thing to experience bleeding during pregnancy?
It's not normal to experience bleeding during pregnancy, but then there is something we call implantational bleeding. So that one is probably when the person has just conceived or something. The person might see some spotting. Even with that, you need to be in a rush to see your doctor to explain this is what you're experiencing. He might want you to do a scan. He would examine you to see if it's actually an implantational bleeding. If it is, they would want to manage you. They would want you to rest and all that to see if it will resolve. Then that's by the way. If you are bleeding and you go to the hospital, we might want to know, is it a miscarriage? Is the baby out? Is the baby coming out? Is it a placenta issue? We have placenta issues. We have placenta previa, where the placenta, which is supposed to be embedded at the, let's say at the upper part of the uterus, is now at the lower part. So because that is not where it's supposed to be, you might be bleeding. The muscles, they are not accepting it, so it might cause bleeding. Or maybe there is trauma or something, the placenta is coming off. You might be bleeding. Okay, maybe there's an infection or something, you might be bleeding. So all these things worry in pregnancy. So your doctor might want to know what exactly is causing the bleeding. So the thing is, there shouldn't be bleeding in pregnancy. If it is, then it's alarming. We'd want to know what is causing the bleeding. Then we would want to manage it accordingly. Yes.
Okay, so apart from bleeding, what other, let's say, danger signs could someone have during pregnancy? Okay,
so if you have somebody who is always complaining of severe headache, the person is always complaining of severe headache, it's a problem. The person has this generalized body swelling, edema, or even the feet are bigger, and people will tend to be like, oh, you are eating well, or you have a baby boy or baby girl. I mean, those are some danger signs. Somebody who vomits excessively, even, you know, most times during the first trimester, some people vomit, hyperemesis gravidarum, but after that, if you keep vomiting, I mean, it's a bit alarming. When you are easily fatigued, when you are easily tired, you are super stressed and all that. I think those are some signs to certain conditions that we might want to probe more into. Or if you are losing your water so early than usual, we might want to know what is causing those things. So those are some of the, presenting factors that might prone that there is a danger coming or something. There are quite a number of them as well. So as a pregnant woman, at any time you feel you aren't okay, I mean, the best you can do is speak to your midwife or speak to your OBGY to see what exactly the problem is.
Okay, okay. So there are some people who don't like the hospital at all.
Yes.
So they believe in home birth, so they'll just sit at home and then they'll like to deliver home. Especially those who have had previous pregnancies, they think they have some experience already. So they go for home birth. What do you have to say about home birth?
It's a dicey one though. I wouldn't say I don't recommend home birth or I wouldn't say I recommend home birth. One, we should look at the setting we are in. If maybe we were in a typical village, even there we have health centers, okay? So sometimes some women, like you said, they would deliver at home. But even with that, they would have to call a midwife from the hospital to come and attend to the person at home. There were cases where I have personally been involved in such situations. I had worked in one region very far away from here, where you have to go to their house to deliver them because they stayed at home to deliver. So that is even a bit different. That is kind of traditional. But if you really want to talk about home birthing, you need to be considerate of the environment. You need to consider the client. Okay, this woman, is she a high risk woman? Is she low risk?
Yeah.
If she wants to deliver at home, her home setting, is it that spacious where we can set up for a home delivery? Is the disposal of is the sewage flow, is it okay? Is the environment clean? Is there an ambulance on standby in case of emergency we can quickly rush to? Is there a hospital nearby? Do we have health workers ready to accept this woman if there should be an emergency? So sometimes when you want to do home delivery, you need to be considerate of all these things. I mean, the economy is hard. So it's not everybody, yes. So it is not everybody that can afford it. So sometimes when somebody comes that, okay, I want to do home delivery, we would take you through all these things to see if you are actually capable of doing it. But mostly we do not recommend it. I mean, we do not recommend it in a part of the world here, but I still know that there are few people who have had a home delivery before. So first we need to look at the woman's condition. We have to look at all the accessibilities to hospital, to ambulance, to something before we'd want to consider that you can actually have a home delivery. So I wouldn't say a no, I wouldn't say a yes. So we have to look at that. But to the side of the traditional area, some of those people actually, you can't push them. You get there and the baby is already out. But it is you still the midwife in the health center that is going to take care of them. So, and sometimes we work with the traditional birth attendants. So it's kind of a two-way. Yes. So I think that is it about home birthing. Yeah. Okay.
So for the mode of delivery, you have the vaginal delivery and the cesarean section.
Yes.
Can someone just say, I don't want to push, I want a cesarean section? Is this something that is allowed?
Yes, I would say it's allowed. But then one thing, we are currently trying to see how we can even reduce the rate of a cesarean section. Most of our OBGYs, they are trying to, because I think lately the cesarean section rate is going high, and it has a lot of few complications. Not let me say a lot, it has complications as compared to normal vaginal delivery. Okay, so we have reasons, we have actual reasons why a woman should have a cesarean section done. We have actual reasons why you should have a normal vaginal delivery done. You know, it's funny, but some women are actually, they are supposed to have a cesarean section, but they'll be pleading that I want to have a normal vaginal delivery. You get it? So you would have few people walking in for a cesarean section, but with that you will need to talk the person, the risks, the benefits, and then you really need to find out why she wants to have a cesarean section. Some people really have tangible or good reasons, so we consider them. So somebody can actually opt for it, but in as much as she has opted for it, you would want to find out more details why she's opting. So in that case, it will be elective cesarean section on account of maternal request. Yes, so we consider it, but then we need to really have good reason why we are considering you for a cesarean section. So mothers can actually opt for it.
Okay. But on the reverse, as you said, some people need the cesarean section, but then they don't want to have it. Why do some people do that? What are some of the reasons they get?
Okay, so I mean, some will tell you some financial reasons. I mean, some as well, they fear. They've had somebody those times, you know, had a cesarean section and there was a problem. I mean, those are quite a long time. Now, the theater is so friendly. Theater is not cumbersome like first where there are lots of things. It's very friendly recently. I mean, you have people talking to you, everybody's there. Even sometimes your family is allowed, your closest family member or your birthing partner is allowed to be there. People fear pain management. They feel they'll be in so much pain, but now there are lots of management we do when it comes to pain. People as well, I don't think I should say this, but I mean, everybody believes in God. I'm a Christian. I hope, there's Hope TV, yes, but regardless, people would come and tell you their faith, you know, they are waiting on something before they come. That is where we also have a bit of issue. So we are still trying to conquer that. I mean, we will be happy if God allows you to have a normal vaginal delivery, you know, but then if it's the will of God, I should have a CS. I mean, He's still there with you, because we have cases where people refuse the CS and they come in a very bad condition. Who are you to blame? Me, yourself, or maybe your spiritual guide? So those are some of the reasons. Just the fear of pain, fear of uncertainty, fear of complications and all that. But like I said, cesarean section is very friendly, lady. There is nothing so scary about it. So before even the section, you will have series of, you know, doctors coming to talk with you, the anesthetist is coming to talk with you, your midwife will come and talk with you, and we are there with you throughout the whole process. So it aren't scary like before. So I mean, it's quite flexible and friendly of late. So I don't think anybody out there should be afraid to have a cesarean section. Yes, it's friendly. When you have good pain management, baby is out, we show baby to you, we even give you baby in theater to hold. Then later, if you want us to have your baby, we take baby to the nursery, you come back from theater, we manage you with the pain medications, and I mean, you are good to go. Okay. So for pregnancy, we're expecting that you're carrying to term, but sometimes you go into labor earlier than you should. What are some of the causes of that? Okay, so that I could say is preterm labor or preterm birth. Okay, so like you rightly said, we presume or we assume that you should have the pregnancy to at least from 37 weeks onward you should deliver. But people are unable to carry the pregnancy till 37 completed weeks of gestation. They might give birth earlier than that. So that is preterm labor or preterm delivery. Okay, so mostly the causes are not so per se, like this is the cause or this is the cause, but then we can talk of some predisposing factors or something like maybe a cause or something. So somebody who has had a preterm labor before could go into preterm labor again. Maybe over distension of the uterus, somebody carrying twin gestation. Okay, so the uterus is quite distended, the muscles are overstretching. So it definitely might go into contractions before the usual. When your water around the baby is too much, it's a reason. Those who smoke, those who drink alcohol, they are also at risk. Those with diabetes in pregnancy, hypertension in pregnancy, they're also predisposed to preterm labor. Okay, and then some vaginal infections can also prone someone to having a preterm labor or preterm delivery. Then stress, so much of stress. You know, you release certain hormones that even cause the uterus to contract. So much stress, anxiety, depression, and all that, they also contribute to having a preterm labor. But then it also depends. So assuming somebody should come with a preterm labor, we would want to examine to see if all the factors are there. Somebody might just have a preterm contractions. That doesn't mean the person is in labor. So with that, we would want to manage the contractions. We would abort it. We have drugs we would use to abort it, and then we manage to see that, okay, you are no more contracting, then you are good to go. Assuming somebody is having persistent, frequent, intense contractions with cervical changes, when you examine with a speculum and you see that maybe fluids are coming out and the cervix is dilating, there is just a little you can do. So with that one, if it's actually preterm, you might want to help to mature the baby's lungs, because as at then the lungs are not so mature. So we have drugs we call tocolytics. You would want to give either dexamethasone to help the baby to mature the lungs. We are giving that because the baby is preterm, born at that time, most of them will have respiratory distress syndrome. They have problems with their respiratory rate and all that. So these drugs will help to mature the lungs as well. They might want to give any other few drugs or management till the baby comes. If baby comes and baby is fine, we would still want the baby to go to NICU for intense observation. When baby is fine, they might just discharge baby to you. So those are some of the little causes of this preterm labor. And then poor nutrition. If you're anemic and you're not eating well, you might also be prone to having a preterm delivery or preterm labor. So those are some of the causes of preterm labor. Okay, but what are the chances of survival of these babies, like who have preterm, who have been given birth preterm? Most of them survive. The premise, you have preemies walking around, and they grow so well when they are being taken care of. They are very brilliant.
Yeah.
I mean, some research says that they are very brilliant and so smart and very intelligent. So we just need the initial care to give them, provide them with good warmth care, exclusive breastfeeding. They need more of the feeding if they can. You can either express or give directly from the breast. So they survive. Depending on the environment as well you find yourself. Yes, the survival rates will differ from maybe a country to a country or a region to a region. So, but regardless, they survive. Most of them survive. As early as 28, 27 weeks, they've survived in Ghana. So I think they do survive well. Yes.
Okay. So postpartum hemorrhage is one of the very big problems after delivery or during delivery, right? What is postpartum hemorrhage?
Okay, so when you talk of postpartum hemorrhage, it's a complication during, or let's say after delivery. It's rare, but it happens. It's there. You know, when it happens, it's so scary. You need a whole village to manage it, and it's one of those causes of maternal death. We are trying to see how best we can curb PPH, that's postpartum hemorrhage. So what is postpartum hemorrhage, like you asked? So it's the bleeding from the vaginal tract after delivery of the placenta. You see that the woman is pouring from the vaginal tract after delivery of the placenta. So mostly people would want to quantify the amount of blood that is lost. Most people will say 500 mils, but mostly you would want to say anything that might worsen the mother's condition. Any amount of blood that might worsen the mother's condition, you might want to term it as a PPH. Then we have the primary PPH and then the secondary PPH. Okay. Yeah, so the primary PPH occurs immediately after delivery or within 24 hours when the woman is still with you in the labor ward or maybe on the ward, or maybe after 24 hours when it happens to probably 6 weeks, then that is what we term as secondary postpartum delivery. Yes. So I mean that is postpartum postpartum hemorrhage. Yes. Okay,
but what are some of the causes of this? Because it's not everyone who goes through this. Yeah, so what predisposes some women to it?
Oh, okay. So like I said, for the preterm labor, somebody who has had a PPH before is still prone to having it. Okay. People with bleeding disorders, that their blood takes longer time to clot, they are at risk of having a PPH. Maybe a woman after delivery, we expect that your uterus should contract, it should become firm and bulky. But after delivery, it's not becoming bulky, it's not becoming firm. You would bleed. If there are clots inside the uterus or retained product of the placenta or the membranes, if it's not out, you will bleed. If your bladder is full after delivery, you are going to bleed. Assuming during the labor you have a tear, maybe any vaginal or perineal tear, cervical tear, even uterine rupture or something, you'll be bleeding. So these are some of the reasons why a woman will have a PPH. And maybe a woman who had in the pregnancy, she was anemic. I mean, she was malnourished. She's also prone to bleeding. A very prolonged labor that is not well taken care of, monitoring. The woman is also at a risk of bleeding. Yes, I think there are quite some other causes of this PPH or postpartum hemorrhage. Yeah. Okay,
but do you have any experience?
Yes, as a midwife, I mean, you would have quite a number of experience. It's not a nice thing, like I said. It takes a village to manage it. So there was this time, I think it was a referral case from a different hospital, and the woman was actually bleeding. If I say bleeding is a nice word, she was pouring. And it was so scary, you know. It was scary. So everybody, so you need to, in that situation, you had to just call for help. Everybody who was on duty came around. All the OBGYs were there, the midwives, the nurses. So what are you doing? You are trying to identify what is causing the bleeding. Is it because there is a uterine rupture? Is it because there is a bleeding from maybe a tear, you want to suture it? Is it because the uterus is not contracted? You might want to massage and, you know, put in some drugs that can help to contract. So as you are doing that, somebody is taking blood sample to the lab, somebody is pushing in a lot of fluids to resuscitate, you know, somebody is trying to check the vital signs of the woman. So you are all working at a goal. You are working together and you are trying to reassure this woman that she'll be fine. She's already losing hope. Most of them, they say very funny things, excuse me to say, yes, that they think they can't make it, they can't survive, you know, but you need to be encouraging them. So you do all these things. If it's not becoming any fruitful, you would want to send the person to theater to do an examination and anesthesia to see exactly what the problem is. If it's as a result of maybe any severe tear, you might want to repair it in theater. If it's as a result of maybe a uterine rupture, you might want to know what kind of, is it a deep rupture or a shallow one? If it's a shallow one that all the muscles are not involved, if I could put it that way, you might want to suture and then hold it back. But some are so intense that there is no way you can even hold it back. So in that situation, you might just want to take the whole uterus out to save the woman. Yeah, so it's quite a terrible complication, but it happens really. It's not so common of late. I think midwives and doctors are doing so well to, you know, already prevent that before it happens. So there are quite some management that are put in place for these people that you might think, okay, they can or they could have a PPH. You actively manage them, even from antenatal to delivery, so you don't have this situation.
Yeah, so that was my next question. What do we do to reduce people's risk for postpartum hemorrhage? Okay,
so sometimes you might want to educate the society. When you are pregnant, you find out you are pregnant, start antenatal early. It will help us to know if you are at risk of any of these things, so we start managing you early. We might want to educate you on your routine drugs to take them, so you are not anemic, you are not malnourished as well. If you are somebody who had a PPH before, we will want to have a critical care, a focused care with you. And one thing is, when you have a cesarean section, you know, the wound takes time to heal. So mostly you might hear that, okay, wait till after 2 years for you to get pregnant. People are unable to wait, so they get pregnant. So in that situation, we might not want you to have a normal vaginal delivery because the scar is not well healed. Okay, so it could rupture at any time, so that's the fear. So in such people, you can't let them have a normal vaginal delivery again. You are monitoring them to a point, then you have to go cut them to bring the baby out. Yes, so in those situations, those are some of the things that can prone the person. So you are looking at those factors to take care of them. So you are looking at those peculiar causes so that you tackle them, so that the woman do not have to go through all those again. So I think those are some of the steps we take to prevent a woman from having a PPH.
Okay.
And then you, as a midwife monitoring a case, you might want to do all your active management. You might want to have everything set. You might want to intensify your management for the woman, so that if the labor is getting prolonged, you might want to quickly intervene. If you see any bleeding anywhere, you might actually want to check where the bleeding is coming from and call on help, so that you don't have the woman having to run into a PPH.
Okay. But you mentioned uterine rupture. What is uterine rupture?
Oh, okay. So, I mean, uterine rupture, it also happens. It's a complication, I mean, or it's a situation. It happens, but it's also quite a bit rare lately. So, uterine rupture occurs when there is a tear in the abdominal muscles of the uterus, or when there is a tear in the muzzle of the uterus. Maybe during, it mostly happens during delivery, but sometimes as well, it could happen during pregnancy. So during pregnancy, maybe there's trauma, there was an accident, or the woman fell heavily on the tummy. So the uterus or the womb can cut up or can tear, and that is quite a very serious complication. At birth as well, it can happen. You know, you are monitoring the woman, and all of a sudden she has this signs that she's having a uterine rupture. So she's bleeding at birth. You might not even hear the fetal heartbeat well when you are checking. You know, her vitals are decreasing. She's restless, and you might not even feel the baby parts when you are palpating well. So these are some signs of uterine rupture. So you quickly might want to get the baby out. So mostly the complication of this, it ends in theater. Because there's no way you can have a vaginal delivery in this case. If the person reports or during labor she has a uterine rupture, you will want to end up in theater to see if you can save either of them. Yes, so it occurs when there's a tear in the muzzle wall of the uterus.
Okay, but after someone has had a uterine rupture and they were fine, can they have vaginal delivery after that?
Okay, so it depends on what the later treatments were. If the rupture wasn't so intense on the muscles, okay, assuming they were able to repair the uterus, the person can be pregnant. But you saying having a normal vaginal delivery, I doubt. I likely doubt that they would want such a person to have a normal vaginal delivery because of the intensity of the tear that was even sutured. They will already educate you on when to even want to get pregnant, and then when you have a delivery, we might even educate you to have a cesarean section. Yes, even some people, the uterus is taken out, so obviously you might not even get pregnant unless maybe some miracle coming. God's give you a miracle baby.
Okay. So we've spoken about antenatal clinic. So I'm guessing there's postnatal clinic.
Yes, there is.
Okay, so how soon after pregnancy does postnatal clinic start?
Immediately after the baby is out, postnatal has started because you have already delivered. Okay, so baby is out, placenta is out. Postnatal begins, so we start monitoring you even in the delivery ward. We'll start monitoring your vitals every 15 minutes. We move to 30 minutes. We move to an hour, 2 hours. Then when you have gone back to the ward, they also take it up from there. So depending on how your delivery was, would also determine your management on the ward. So some hospitals might, after you have been discharged home, you are well. On the day of discharge, we do a postnatal assessment. If your uterus is gone back, you know, if your bleeding has minimized, it's not reddish, the blood coming is not so reddish, if your vitals are okay. After delivery, we still do series of labs to see if your blood level, your hemoglobin is fine. We would want to know if your baby is fine, baby has passed poo, baby is wee-wee. So we will do a thorough assessment on the baby and mother even before discharge. So when you go some places, after 3 days, you might come back for postnatal assessment. And we are still going to assess you on what we did before you left, your vitals, your baby care, yourself, your wound, your healing, your perineum. After 1 week again, you would come for postnatal. We do all this assessment. Then you come again for 6 weeks. Then you come again for, I think, 14 weeks, you come again for postnatal. But anytime you are not well, you can come for us to examine you. You don't have to wait till the given date before you come. So you can come as anytime you think or you feel you yourself or your baby is not well, you can come. So for we midwives or OBGYs, we take care of you from pregnancy to 6 weeks. After 6
delivery.
weeks. Yes, after 6 weeks, we refer you to the general practitioners. Yes, so we at Ops and Gynae have a duration where we take care of you up to. Then we leave you to the general practitioners to continue from there.
Okay, so we are learning a lot here, but we'll go for a quick break and then we'll come back. So please stay tuned. You can send in your questions and comments on YouTube, Facebook, and also on WhatsApp. Please stay tuned. We'll be right back.
Lords. He is the Alpha and He is the Omega. He is God all by Himself. There is no other God that can be compared to our God. He is such an amazing God, and we love Him because He has first loved us.
Oh yes, come and meet Jesus at the Goldfields Junior Staff Clubhouse, Akon Takwa, on Saturday, 29 July 2023 at exactly 9 a.m. as Hope Channel Ghana and the West Central Ghana Conference invite you to the All-White Family Prayer Conference. I will be there together with your favorite pastors. So come prepared to be inspired and experience Jesus to equip you to lead your family in prayer with wisdom and purpose.
Kai said, Womua and Ama Hope Channel. Actua so jijumedie sonko abesi sa empempensui enti wo ba fa bibi hye wabosuo mu anase fa bibi hye wo botomu a o de ba beboa Hope Channel eye dwumedie ahodo a yedie no kai se dwumedie e ba so eye memeneda 29th of July 2023 Hope Channel Ghana, 5 years of changing and impacting lives.
Minia, bra. Brahma and Kwati. Hope Channel Ghana, Miatia Sam Do, with our suppose made that also at your son. I think Pinonia do me some. And as a picture or say, ye dear American Suo, ye free you my braces cola, ye nemu kakra from Fadam Foy. Let me unfriend me, ye Quabrica, and ye Kakra noir, ye didn't know. obia benya ne chefa uni se apomodin ya papa ye wie pe na ye ko community center eho ane de aerobics no ye de kwa hyehyɛ so enya asam kitwa wo me pa cho hwompa bo wate na bra na apomodin won fa so bebre Hope Channel in Fenum no takwa for ye ne mu na ehia bomu enya asam kitwa Hope Channel Ghana yes is abrapo Hope Channel ye ma enida so Takwafwe asem dabo Hope Channel Ghana ye ba mabobo ano pair ye ni West Central Ghana Conference of Ezi Kuta wasabosome ne de toso aduonu nwotwe afimpinu ne aduonu miese ya
ye ba chunchum ne ye onyankopon aye bre a Hope Channel everyday one enuma fashe no nyum to kwa ya to yensa afa won ye Takwa Central kwa Amazing Grace Church kwa Etuabo Church kwa Akon Church kwa eni ahudro pi
so fanyina wati dwam na wodi dwumadi ababa eye so for God's hold akosi ajeman na wati na ye nidi enko a Hope Channel yes sa abrabo Hope Channel ye ma enida so
I am an angel of hope.
I'm an angel of hope.
Ubreni o so do sika ebeba beboa Hope Channel na waso ya sene ye tumidi da me asem no akọ omantwi aso ne ni tworom nyana wadaroma fa homan na fa usika fa so bi na onso fa bra ne ko kanyamsem anya akra ewu nkwa *928 *34 *104 hash anase 0249 193083 Hope Channel yes sabrabo Hope Channel ye ji akra no nkwa
Welcome back to the consulting room. So Dede, during pregnancy, when we're talking about pregnancy, we are usually talking about women. Do men have any role to play during the pregnancy, even during delivery too?
Of course they do.
Okay.
I mean, pregnancy didn't come by just the woman.
Yeah.
So it's a two affair.
Okay.
It's just rather unfortunate that most often we do not so much involve the males or the husbands into the pregnancy journey. But I think in recent time, we are looking at how to involve them in the pregnancy. Some naturally just do not want to be involved. Okay. Personally, during school, I did a research on male involvement in antenatal. Okay. Interestingly, when I went to the field to collect data, some told me, no, theirs is not about the pregnancy. They have to go and look for money. They don't have time. You know, I was like, really? You get it. So, I mean, we are trying to see how we can clear that off from the minds of some men. But I think in recent time, a lot of men are getting involved in the pregnancy journey. Where I work, when you come with your husband for antenatal, you are cared for earlier than somebody who had come just alone.
Oh, I see.
Yeah, so we are trying to see ways at which we can encourage the men to come. Some of them are a bit impatient. They were like, you come and waste all the time at antenatal and all that, you know. So we are also trying to see how we can deal with that. But regardless, we are going to spend time because we are looking at focused antenatal care, person-centered antenatal care. Okay, so what we are doing is we are encouraging men out there, like husbands or partners out there, to be a part of the pregnancy. Sometimes when the woman is just alone, when you educate or say certain things to her, some tend to forget. They do not remember. But when you come with your partner and then we have a long talk, an intense talk, they also realize that, okay, this is what's supposed to be done. I should help my wife at home. I should be able to buy this for her. These are certain signs. Even if she's not seeing it herself, I am seeing it. So when the men are involved, it makes it so complete. It makes it whole. Yes. So I think men should, I think men should actually, or partners should actually be involved in the pregnancy journey. Come to the antenatal with your wife. see her through the journey, be with her through delivery. You know, we are encouraging men to be in the delivery suite, in the delivery room. Few of them come. Some will tell you they can't stand the pain. I have lots of cases when we want the men to be there, they tell you, I can't.
Yeah.
I can't bear to see my wife in the pain. Some will tell you, I can't just stand it. Some few of them come, and you even want them to support the woman during the pushing time, and they can't.
Yeah.
They're like, I can't. You know, I have funny cases when some come in. As the wife is pushing, he's tearing off his shirt. So the time the wife is done pushing, his shirts are off. Some will throw their keys away. You know, we have some tearing or crying. There was a funny case like that when the woman was pushing. The husband, he fainted. Oh. So we had to leave the woman now to attend to the husband. You get it. But we have some few ones that are bold. They would want to be in the delivery room with their wives. You know, like I said, our setting is a bit restricting, mostly when they also come to the labor rooms, because it's an opened one. So if you don't have something to divide to provide privacy, and there are 2 or more women, it's a bit of a challenge having all of them having their partners there. But then regardless, we are having improved systems. We are working on having that individualized suite that you can have the partners or any birthing partner with them. So what I would say is men or partners should be involved in the care of the women. It helps the care. It helps the you know, even the unborn baby feels some kind of, you know, combination from both the mother and the father. The woman also feels okay. She's relaxed. She's not so worried, you know, because she knows that her husband or her partner is involved, you know. Men actually listen. They help a lot. So sometimes you have some of them coming and they're like, my wife doesn't do this. When you tell her that she doesn't do, so it helps us to even catch the woman who's not doing the right thing, you see. So I think that the men should be part. Those who are already part, we want to say thank you and congratulations for always coming. We would want you to come more often. It's not easy though, but I mean, it's so not easy for the woman carrying that baby for the whole 9 months and even beyond. So you shouldn't have any reason that, I mean, you can't. So maybe once a while you should be involved. We are actually educating and, I mean, trying to see how we as health workers or we as you know, obstetric and gynae team, we can encourage men or male partners to be part of the pregnancy.
I think this will be our last question. You mentioned that in some pregnancies there are like complications or like the high risk pregnancies, so we don't encourage that they get pregnant sometime after they've delivered. So how soon after delivery can they like do family planning services? Oh,
family planning can be done, I mean, immediately after birth.
Okay.
Yes, immediately after birth you can start family planning, but then it depends on the choice available or maybe the choices that you can do. Family planning, you know, exclusive breastfeeding is also a way of it's also a form of family planning. So if I say that it can start immediately after birth, that is one of them. Exclusive breastfeeding works for some people, but you need to know. Yes, some people. Let me say everybody. Some people. So that is one. There are lots of other available choices. The injectables, the pills, but it is not all of those a breastfeeding or a new mother can take. So we have those that they can take. So in that situation, we would want to give you the decision. We would give you an informed choice, so that we would want to educate you to be informed on the available choices. Then the one that suits you or is within your range, we would provide that to you if you want it. We might also want to refer you to the family planning nurse so that you can have an intense conversation with the person, with your partner involved as well. So even after delivery, there are some family planning options that are available. It's not like there isn't at all. We have some injectables that the person can take that is okay for you to take even when you are breastfeeding. So there are lots of them available.
Okay. So we've learned a lot today. Thank you so much for coming. We'll invite you again, definitely.
Thank you.
If you have any final words for our viewers.
Okay, so a little I would say pregnancy is quite delicate. It's so uncertain. The fear, you don't know what is coming out. So my say is, when you realize you are pregnant, do your best to visit the hospital. Go for your antenatal classes, antenatal school, antenatal clinics. Ask any question you need to find answers to. We, the health workers, might be in a hurry. We might be in a hurry because we want to attend to everybody. We might not get all the time, but try to ask every question you want to clear your mind of. If you can read, you can go to the net and read a lot. If you do not understand anything, call your OBGY, call your midwife, call your nurse and get all the details. If there is any care we are giving you and you do not understand, you are allowed to ask us, why are you doing this? Why am I supposed to do this? So that you are okay, you are fine. And then last one, please try and go to the best of hospitals. There are a lot of hospitals around, not on a bad note, no. Yes, there are lots of hospitals, but I mean, try to go to the ones that are, I mean, in case of anything, they are quickly there for you to keep, because we want to save our mothers, we want to save our babies. We do not want to lose either of them. So do well to visit the hospital when you are sick, when you are pregnant. Make sure you take things that you are supposed to take as a pregnant woman. Speak to your doctor anytime you want to speak with him, and then read if you can.
Thank you so much. So this has been a very interesting discussion. I believe we've all learned a lot and added on to the knowledge we already have. Let's not take anything for granted during pregnancy to ensure we have a healthy mother and a healthy baby. Thank you so much for joining us today on the consulting room. Have a good night.
He is the Lord of Lords. He is the Alpha and He is the Omega. He is God all by Himself. There is no other God that can be compared to our God. He is such an amazing God, and we love